Cool. So it's kind of an interactive lecture. There's going to be a few question and answers. If y'all have any questions throughout this entire presentation, feel free to let me know and we can stop where we're at and we can go from there. But pretty much this is a day in the life of an internal medicine resident during COVID-19 pandemic. As you guys know, I'm Dantwan Smith. I'm a second-year internal medicine resident at Magnolia Regional Health Center and one of the co-chairs of the Physicians in Training Committee. So we'll get started. So an outline for what we will go over today. First, there'll be an introduction. Then we'll go through a typical normal day as I am resident at MRHC. Then we'll go through the changes that have occurred with COVID-19 and what all that entails. We'll do a brief intro into COVID-19. We won't get into so much of the details because you guys have probably been bogged down with that, but we'll go to some of the high yield points. And then we'll go into a little bit of the management and treatment with COVID-19, some nuances that we're doing at my hospital, some nuances that I think will probably come out in the future to come. Then we'll go into a Q&A, and then after that, we'll have any announcements that we have by the committee. Sounds good? All right, so just a brief intro. I'm from Columbus, Mississippi, and this is actually, if y'all can see my arrow, like right here, it's gonna be about maybe a couple of hours south of Corinth, but kind of north central Mississippi, but that's where I'm from, born and raised. I went to Ross University School of Medicine, graduated from there in 2018, and I also graduated with my MBA from the University of West Alabama in December of 2018. As you guys know, I'm a second-year internal medicine resident, and I'm applying to cardiology fellowship this year that's coming up in June, which is fastly approaching. So hopefully I will match somewhere that's in the South, hopefully either Mississippi or Alabama. And I enjoy doing a lot of community service. So I'm a very big, strong advocate for community advocacy and community education. So here are just some photos of some of the things that I do in my spare time outside of residency. So this is a picture of me at a health fair that I conducted at a church in Alabama. And pretty much we just did a lot of blood pressure screenings, talked about, hyperlipidemia, hypertension, diabetes, things of that nature. And then this picture down below is in Caledonia, Mississippi, which is about maybe 10 minutes away from where I grew up from. And this is the middle school and high school students at their career day. And I just went there to talk to them about the field and career in healthcare and answered pretty much any of their questions that they had. A lot of them thought that, healthcare field was like what they see on movies, but, I told them that's pretty much not what a typical day entails. And then here is a picture of me. I do have a nonprofit organization called the Inspirational MD, and I go around to educate the youth about different healthcare poverties and healthcare disparities and things of that nature, just to try to raise up a different generation to be more equipped and better educated. But here is a sex education one-on-one seminar that I perform once a year for the Kappa League, which is a fraternity organization. They have an initiative to help out younger children, and I do that once a year. So a normal medicine day service, typically we have a cap of 28 patients on a normal day. And this is for 2 upper levels, so a second and a third year, or 2 second years, and an intern. And also we'll typically have, maybe about 2 to 3 medical students, typically 2 third years and maybe 1 fourth year. And the 4th year would typically be like an auditioning student. So that comprises the medicine team along with our attending who supervises the rounds. And then we have a case manager as well as a pharmacy student or pharmacy resident. And then in addition to case management, and then the nurses who are there on the floor. So that comprises our full medicine team. So typically a normal day sign out typically begins at 5:45 a.m. There we'll hear about any types of acute events that have happened overnight with our patients, any medications that had to be given for our patients overnight, things like that. We'll hear about it there. And also we'll hear about any new admissions that came in overnight that we'll have to take care of during the day. So that happens from typically 5:45 to 6 a.m. And then we'll pre-round from 6 a.m. to 8 a.m. This means we, look up the patients, get to know them really well, look at their charts, labs, anything that might have happened that may change the course of their hospital stay. And then we'll also go and go examine the patient, talk to the patient, get to know them, things like that. And then, pretty much give them the rundown of the care plan. And so we'll do all of that typically from 6 a.m. to 8 a.m. We'll also get with the medical students, go through the care plan with them as well as the interns. So with our cap of 28 patients a day, the upper level split at 14 and 14, and then the interns cap is 10 patients. Typically the medical students will see somewhere between 2 to 4 patients. So that's how we break up the whole patient list and things like that. Whatever's left over, the upper levels will see. And then anything that's over 10 patients, as far as admissions, we'll see things like that. So in addition, we'll also have like clinic days that'll be incorporated here, things like that. So that encompasses our pre-rounds. Then we have our attending rounds, which are quote unquote official rounds from 8 a.m. to 10 a.m. During this period of time, we go by see the patients together as a group. We'll get a formalized and more concrete care plan together that's more set in stone. Then as well, the attendings will, ask questions, quote unquote, pimp you, things like that. And then as upper levels, we'll ask the interns as well as the medical students different types of questions. Typically, we try to gauge the questions for as medical students to, encompass their board exams. We don't want to get too in depth with the nuances of medicine as far as discharging, where they're going to a SNF versus LTAC, things like that. We want to try to, hit them where they're at and ask them those board style questions. And then from 10 a.m. to 11:45 a.m., we're getting admissions, we're putting in orders, discharge orders, things like that, any procedures. So one thing that's kind of unique in my program, we actually do all of our procedures. So any thoracentesis, paracentesis, arterial lines, central lines, we do all of those things, intubations, lumbar punctures, you name it, just about we do it, anything like that. So we do all those things. And we also have a resident service as well when we're on medicine that we get any consults for procedures for non-service patients. And in addition to that, we run to our own codes, so or rapids. So we have a code team, we have a procedure team, and this alternates each and every day. But we run our own codes, and we're able to move patients to and from the ICU at our leisure, given the attending is aware and is okay with the care plan. So that happens from 10 a.m. to 11:45 a.m. And then from 11:45 a.m. to 2 p.m., we have noon conference. And this pretty much entails hearing any announcements from 11:45 to 12 from the hospital, from our program director, assistant program director, or our designated organizational institute personnel, things like that. And then from typically 12 p.m. to 1 p.m., we'll do like a mix-up lecture. So a lecture geared to maybe nephrology, cardiology, or we'll do EKGs. We may even do like a mix-up question bank, which is sort of similar to like UWorld, but it just kind of gears us to be ready for our internal medicine board exams. And then from 1 o'clock to 2 p.m., we typically have afternoon report, and this will be a case presentation about something that we may see, day in and day out, or something that we very well may not see. So we may talk about on Monday, hyponatremia and case report, or Tuesday we may talk about a cryptogenic stroke or something like that. So it can vary. It just depends on the program director's discretion. And so after that, 2 p.m. to 5 p.m., we do typically the same thing that we did from 10 a.m. to 11:45, and then it sign out at 5 p.m. So that's pretty much how a normal day goes with medicine for me. And yeah, it's pretty much how it is. So changes with coronavirus, with COVID-19. So now we've had a team I. So typically we have team A and B, which are a resident team. We have a team C, which is a nurse practitioner team that's led by a physician. And so they pretty much have a cap of 28 as well. And then we created this team I, which pretty much stands for infection. And so all of our COVID patients or even suspected COVID patients will go to this team I. And so team I, we actually have one of our ICUs that's secluded just for PUIs, what we'll call as people under inspection or patients under inspection, and our definitely positive COVID patients. And then we also have a regular floor that's purely dedicated to COVID patients who don't need ICU beds. So this was one team that was created. Again, it has a cap of 28 patients for 2 upper levels and for 1 attending. It hasn't gotten to that point in time yet, just with the turnover with tests. So typically it takes about, when it first hit, it would take about maybe 3-4 days for the test to come back. But now it typically takes about 2 days. At one point in time, it only took 1 day, but now it takes typically about 2 days. And a lot of the time, I say majority of the cases that we get, we don't suspect it, but we just have to rule it out. And so, this is one of the teams that we've been working with. It's just like a medicine team. We see, acute respiratory failure, acute CHF exacerbations. We see a host of other things. There was also a brain herniation that came in. He was really a case and he was really, really febrile. Thought it was coronavirus, ended up getting a CT head, and it was actually a herniation. Also diagnosed a bunch of meningitis cases. So, COVID-19 is the, diagnosis of exclusion in a lot of these cases. And we really don't want to get, bogged down or anchored, as I should say, that, okay, this patient has COVID-19. Let's just wait until the test comes back. And then when it comes back, we know what we're dealing with. We have to rule out other things that could be causing, the patient's acute respiratory failure too. So other things that we have changed, there are no group rounds with COVID-19. As you know, we want to keep the social distancing with this pandemic going on. So typically we'll just do, computer rounds with the attending, split up the patients, whether it be resident 1 may have 8 patients, resident 2 may have 8 patients, and they would, typically round with the attending separately. So that's pretty much how we've been doing it from that standpoint. We've also been having Zoom noon conference instead of actually going to like a building and congregating. Our noon conference would typically be a room of about maybe 30 to 40 people. And this would encompass residents, medical students, GME staff, attendings, and any guests that we have. So we've been transitioning over to Zoom, which has been a good use and a good media that we've been able to use with doing our lectures and things like that. And so we've also had a daily Zoom conference just to update us about different changes with COVID-19. So as you all may know, a lot of things as far as like PPE and different medicines that we usually use on a daily basis aren't readily available. So that's what these meetings are about, to let us know, hey, we're running low on ketamine, so you may want to kind of, use it judiciously, or we're running low on, this number of PPE, all those different types of things we want to kind of keep in mind and, get updated on those things daily, because who knows, someone may know about different resources that, we haven't tapped into and things of that nature. And we may be able to get those resources a lot faster if we, essentially let people know. Another thing that we've incorporated here at our hospital is a one entrance inside the hospital. So one way in, one way out. Of course, during an emergency such as a fire, we can get out, but we've been only allowing people to come in one way in and one way out. And then this is a way we can kind of check temperatures, and kind of screen for any kind of symptoms and things like that. And to this day, we haven't had an employee to get sick with coronavirus. We haven't had an outbreak in our hospital, which is very, very good, and kind of just solidifies that this modality is kind of working. And then also with our patients that come into the hospital, if they have any suspicion for coronavirus, they actually go into a different entrance that's kind of a little bit on the backside of the hospital, and they get brought in that way to make sure that everybody that they come into contact with has on full PPE. And so another thing that we've been utilizing is our PPE. So we know that this is a thing that's been going across the world, not being able to get PPE. We've actually tapped into other resources such as Lowe's and different other organizations, community colleges, undergraduate schools that are local that have been able to kind of help us out in this area. And we've been actually able to conserve a lot of our PPE by utilizing paper bags before going into like a patient room. We'll have our PPE in a paper bag and just to be able to utilize it again as far as like masks and goggles, things like that. So of course with gowns, only one use, but with other things like that, like I say, mask and goggles, things like that, we've been able to reutilize those. And so another thing, responding to colds or rapids, anybody that has respiratory symptoms, when we go into the room, you must have PPE on. It's not a matter of, just goggles or face mask with shield. Everybody must have PPE on going to these rapids and colds. And then another thing, we also have a machine that we can use that will automatically do chest compressions in patients with COVID. So if we know that they're about to probably code, one person can go in, set them up on the machine, and then essentially the provider can be the only other person in the room along with the nurse to give medications, but no need for a whole row of people to go in and do chest compressions because we have that device there. Another thing, medical students, they have been relieved of their duties during this moment in time, as you all probably already know. But just with talking with them, they've been getting communication from their schools. And it looks like the rule is they're going to be able to do 4th year and 3rd year rotations, but only at their facility. But it's not something that's set in stone just yet. It's just speculation. So that's something to come. And then as a program across the board, probably in many different residency programs, we do resident outings. In my class specifically, we do at least a 1-month outing. But of course, again, this has been placed on hold. And we've been actually seeing, some patients come in with depression and things like that. And, this is kind of a big thing, mental health as to, making sure that residents are, maintaining their mental sanity and mental health. And we talk to each other often and, ask each other how we're doing, things like that, just to make sure that everybody is still, holding strong, during this pandemic. And so with the regular floor patients, we've seen a dramatic decrease in our census on just the regular floor patients, especially when we had a shelter in place. We saw our normal census typically would be about maybe 15 to 20 patients. This census went down to like, some days we would only have like 7 or 8 patients, and that would be split up amongst like 4 or 5 residents. And so and this is for 2 teams, so a total of 56 cap would go down to like 7 or 8 patients. So, that was something that we were dealing with for a while. A lot of people at the hospital did get furloughed, but with the shelter in place starting to kind of be weaned away, we've been seeing an influx of patients, in our hospital census for regular floor patients has increased back to just about regular numbers now. And so, with that being said, Team I has been getting, an influx of patients, and the turnover is kind of pretty quick, like I say, with testing. So when patients get admitted to Team I, we'll get the test. If they're COVID positive, of course, we'll keep them. But if they're COVID negative, we'll send them to the floor or to the IC, to the regular ICU, and they'll be managed and treated from that standpoint. So here is the total cases, and this was as of yesterday in Mississippi. And so it's broken down, the colors there, as you can see at the bottom. We have a total of about 9,600 cases. We are, in my program, we are up here in this area up here, all the way at the top, top corner, pretty much, top right corner. And we have a total of about 10 cases. But we've been seeing cases from the neighboring county and other neighboring counties. And so we've been actually, you know, like I say, we've seen more than that. We've only had one death in the county, but we've had about maybe 5 or 6 deaths now total. And again, this is, of course, outside of the county as well. But this kind of gives you a picture and a glimpse as to, you know, as far as different ethnicities, how they're dealing with COVID-19. And as you can see here, the African-American population has seen a great spike in cases as compared to other populations. So we, like I said, we have a total of 435 deaths, again, more with African-Americans as opposed to other populations. So I wanted to talk to you guys about a little bit of medicine, something that you'll probably see on step 1 and maybe even step 2, but this is like the replicative cycle of enveloped RNA viruses. So coronavirus is, or SARS-CoV-19 is a enveloped RNA virus. So if you kind of understand how the RNA virus replicates, you can kind of understand the treatment modalities and things of that can kind of attack this virus. So as you can see here, the virus is composed of a capsid, RNA that's in the middle, and then you have this envelope that's on the outside too. So when the virus, the first step, again, you'll see glycoproteins on the viral envelope, and this has a specific receptor that it binds to, and then the RNA virus is inside of it. And then so you have digestive enzymes that are in the host cell that break this glycoprotein down and just gives you like the viral genome just by itself. And so with the genome, they use this as a template for synthesis of further strands of RNA by using RNA polymerase. That's something probably you haven't heard of in a while, but using RNA polymerase, and this causes new copies to be formed. So replicating this viral genome that you have up here, new strands are made, and then these new strands that are made, they go into, again, a glycoprotein coat, and then once it gets exercised from the host cell, you get this this capsid around it, as well as the envelope around it also. It's comprised of these glycoproteins too. So and then over here in step 6 and 7, step 6, excuse me, you get these vesicles that kind of transport these capsid proteins. So they're made by themselves, and so they get in the endocytosis and get essentially excreted to the surface. That way they can get on the capsid and go from there. And so here are some different, I found this pretty interesting, some different lines of attack or different medicines and how they work on coronavirus. And so pretty much, again, it goes back to, you know, knowing the mechanism of how RNA viruses replicate, and each virus is going to have its own receptor, of course, and it's going to have its own mechanism of how it replicates. But for the most part, all of them use the same steps to replicate and things like that. So with SARS-CoV-2, you have this glycoprotein on the outside of it right here. You do have different medicines like monoclonal antibodies that attack the glycoprotein. So if you don't have the glycoprotein coat on the outside, then it won't be able to attach to this ACE2 receptor that's on the outer cell wall. So that's one mechanism of action. The other mechanism is this chemostat that acts at this other receptor that allows the virus to come inside the host cell too. And so once it attaches to ACE2, then it essentially releases the RNA again because it's trying to replicate. And so then it goes into this translation. So trying to make more mRNA and RNA, things like that. And so this step 1B part, this is where plaquenil or hydroxychloroquine actually interacts with the cell. So it kind of acidifies this endocytosis portion and kind of makes this portion degrade. And so once that degrades, then the virus essentially can't get into the cell from that portion. So that's kind of how it acts. And then you have other different forms of medication that inhibit proteolysis. The lopinavir and ritonavir combination inhibits this portion. And the remdesivir, which you may have heard in the news, actually inhibits the RNA-dependent RNA polymerase. And then you go on down, so on and so forth. You get your other steps of RNA replication and how the coronavirus essentially makes more of itself. And so one thing that was actually released today was ivermectin was FDA approved today for coronavirus, which is kind of interesting. I'd look more into that, but one of my colleagues showed me that earlier today too. So that's one thing that you can do. And this is a good chart to kind of just keep in your back pocket, because you'll probably see this in the future on step exams and things like that. So in the ICU, pretty much across the globe, people have been using Plaquenil. And one thing that we have seen, patients that are on Plaquenil, they're on it chronically for like lupus or something else. They typically don't have as a severe course. As a matter of fact, an indolent course. One of our patients that's probably doing the best is a 91-year-old. She has lupus. She's on Plaquenil. And she came in, was on a high flow, which is like a more quote unquote invasive oxygen modality, but she was on it for maybe a little while, and then pretty much got weaned off, and now she's been on room air and doing very, very well. And so one thing that she really didn't have as bad of a respiratory course, but she did end up having going into acute renal failure. And our nephrologist, actually, which I'm rotating with him this month, our nephrologist, he actually, they have studies out there that say that the coronavirus, of course, with the ACE2 receptor, it's able to get into the endothelium of the kidney and able to get into the glomerulocytes and things like that, and able to kind of inhibit different processes and things like that. And so with Plaquenil, with her, we didn't, like I say, the respiratory part was kind of indolent, but she did end up going to acute renal failure and had to get on dialysis. So it's of question if these other modalities, such as remdesivir or leponavir, ritonavir combo, will be of use with to prevent like renal failure and things like that with these patients. And then also, we've been seeing these microthrombi and this prothrombotic state. So a lot of these patients have been having strokes, MIs, and things like that too. So I wanted to talk to you guys about the social determinants of health. This is something that kind of plays into a factor of that slide that I mentioned before, with African Americans being the most most profound group that's affected by coronavirus in Mississippi. So the five areas of the social determinants of health are economic stability, social and community context, neighborhood and environment, healthcare and education. So a lot of people in Mississippi, as far as the African American population, it's a good portion that do not have insurance, good portion that do not have economic stability, especially during this time of, coronavirus. A lot of people are out of work, have been furloughed, and, we've gotten the one stimulus check, but at the same time, there aren't a lot of benefits out there for them, especially for families that have multiple children, or multiple people that they need to take care of, things like that. So, and then with social and community context, that kind of, we've been trying to get more things out there as far as, um, resources. But again, if you're not able to keep your television on, if you're not able to keep your cell phone on, how are you able to see these different types of things that are going on in the community that may help you out, or may provide education to these specific populations. If you don't have the funds to keep those things on, then, you won't have, you won't be able to get those resources or benefit from them. And then in addition to that, neighborhood and environment, a great deal of the population, especially where I'm at, we see a lot of people, just passed down from generation to generation, or in this one particular neighborhood that people aren't used to going to the hospital. They don't want to go to the hospital. They think that doctors are bad, all those different types of things. They don't want to spend money on medications. This kind of trend is, being passed down. And, although it's good they may be staying at home, what we've been seeing a lot too is a lot of people, they may have CHF and they've been eating a whole bunch of salt, and now they're coming in and it's almost too late. Or a patient may be a diabetic and now they have a diabetic foot ulcer and now they're getting amputation. So, that kind of stigma in those different populations has kind of been affecting us. And then with healthcare, we've talked about, and then again, education, that impacts us from all different types of aspects. If our patients aren't educated, then, essentially how are they going to be able to, take care of themselves to the best of their ability? How are they going to know when to come into the hospital, when to stay at home, and things like that? So I feel like the social determinants of health is a big, big thing that is kind of getting put on the back burner during this coronavirus pandemic, but it should be something that we should always consider. And so here's just, again, different things that like a neighborhood connections with the different types of social determinants of health, different things that can help out the patients and things like that. So social integration, with church, your, schools, things like that. So all these different types of things come together and convalesce to help out our patients, to help them do better, and to help them be overall better patients. And I also try to challenge my patients to not only keep the information that I'm telling them, to themselves, but to also, express concern with their families. We talk about a lot of times in family gatherings, like Christmas, Thanksgiving, July 4th, a lot of different things, but we rarely ever talk about healthcare and how their health is doing. And I, try to allude to them to, talk and discuss about those things. And sometimes you may figure out, hey, I have this family member that was actually in pretty bad health and they just didn't know about it. And, they were able to kind of help them out and kind of educate them a little bit better. So I kind of want, my patients to take their healthcare into their own hands. Yes, I'm here as a connector to equip them, but at the same time, it's their bodies, it's their health. I want them to, equip themselves as well. And so that's pretty much all I have. If you guys have any questions, feel free to ask.
I'm wondering, have you noticed any changes to your requirements for your second year of residency or to the other years, maybe?
Yeah, so with residency across the board, you have to have so many days of clinic to graduate. And so with the third years, those things have kind of been, put to the side. Of course, still go, but if you don't get your clinic days, don't worry about it. Other things have kind of been relaxed as well, as far as like different rotations. So for example, we had a resident who we normally do our geriatrics rotation in Tennessee, in Memphis, which is like less than an hour away. And so we normally do it there, but with everything going on, you know, of course, they don't want outsiders in. And of course, we don't want one of ours going up there and, you know, getting coronavirus and bringing it back to us. And so what happened with that is he was able to kind of modify his curriculum for geriatrics for that month and was able to do something else. So, yeah.
Do you guys have any plans to change the format of interviews for your incoming first year residents?
Right now, we don't. Of course, it's going to be like a, you know, case by case thing, or as such to say, you know, once we get there, we'll probably deal with it. Not right now, no. I imagine probably typically interviews start around like October-ish, probably like around maybe August. We'll probably start thinking about that a little bit more judiciously. But as of now, no changes to the interview process as of yet. And likewise with fellowship, I'm sure it'll probably be the same thing with fellowship applications and interviews. It starts a little bit earlier, typically like around August and all the way up until November.
Yeah, have you guys been affected as far as taking your board exams? I don't know what year that is. Is it second year?
Yeah, so as a second, in my program, you have up until your second year, halfway through your second year to take your step 3 exam or level 3. We've already taken all that. We took that last semester, but the medical students have been affected the most out of anybody. And of course, as you know, the step dates have been pushed back, such as in level 3, level 2, level 1. And then in addition, step 2 CS is now going to be electronic. So that's something else that's been kind of modified as well. So kind of a good thing, because I feel like step 2 CS probably really didn't have to be in person. So I actually think it's a benefit to you guys. Okay. Well, I appreciate the Southern Medical Association for giving me this platform. And of course, my co-chair, Natalie, for being here, as well as Mandy and Jennifer for being on the call. If you guys have any questions or concerns that you would like to ask in the future, feel free to email me or ask in the physicians in training group. That way everybody else can see. But I really appreciate you guys for giving me the time to kind of give you a scope as to what my day is comprised of and how changes with coronavirus has kind of made us kind of detour from that. So appreciate it.